welcome and thank you for coming to this webinar series from the Eye and Ear Foundation called Sight and Sound Bites. This bi-weekly webinar series highlights research at the University of Pittsburgh School of Medicine. Today's topic, a very interesting one, it's called More Than Meets the Eye, Genetic Counseling in Ophthalmology. I'm Lawton Snyder, CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck, and at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support. So we greatly appreciate everybody who has supported us, who is on the webinar series today, and we certainly welcome and encourage people to support the program if this, even to support what you're going to hear about today. So some housekeeping rules. This is a Zoom product, you probably recognize that, but for today, we disable chat. So don't try to chat your friends on this webinar, but we do use the Q&A function down below. So you look below and you'll see a bubble, it says Q&A. Please type your questions in there. We look forward to answering those, and I'll read all questions at the end of the program to the panelists. Please refrain from asking personal health questions that only would be relate to you and not the rest of the group. I may pass those up, but we will try to answer everybody's question either on this webinar or afterwards. We will send out a survey tomorrow that you'll receive. We ask you to please fill that out, and then we'll share that with our group. We'd like to get your feedback, and you will be added to our email list for future webinars. So part of the panel today, and to help us introduce the program, is our distinguished professor and chairman, Dr. José-Alain Sahel, for the Department of Ophthalmology. Dr. Sahel is distinguished chairman, professor and chairman of the University of Pittsburgh School of Medicine, exceptional class professor at Sorbonne University in Paris, and the Eye and Ear Foundation endowed chair. Dr. Sahel, would you please introduce the program?
Thank you very much, Lonnie. Welcome, everyone. So thanks for attending this seminar today, this webinar. Very pleased to introduce to you two key players in our department that are playing an important role in helping our patients to cope with a very complex disease. So when I joined this department in Pittsburgh almost 5 years ago, I was very happy to realize that Dr. Nischal, who just joined us, had already built a team around genetic counseling as part of the activity that is occurring at the children's side of the department, which is very important in many respects. Because my own core interest, not exclusive interest, but core interest is in genetic disease of the retina, I always benefited while in France from genetic counseling, and I know how important genetic testing is in these diseases. And we were able, thanks to the support of UPMC, to recruit one more genetic counselor, Michelle Alabek, who is with us today. And just to describe to you, and maybe Dr. Nischal will chime in on that, to describe how it occurs on the children's side, but when we see a patient with a complex disease and we believe that there is potentially a genetic underlying cause, we need to provide the opportunity to perform the genetic testing. But because, first of all, it's a very complex type of testing, because the amount of information that has to be managed is very, very wide, very broad, and very deep, there is a need for a dedicated expertise for that. The other part of it is that it's not easy to understand this information. It's not easy to manage it for physicians, but it's even less easy for patients. And someone has to spend time and explain that. And we have to do that as physicians, but there is a very specific set of skills that has to be deployed to make it understandable and useful for the patient. And also the fact that sometimes we just don't know. We just have to cope with what we understand, what we don't understand. And genetic counselors are not just focusing on looking at a sequence of genes, they are really focusing on what it means for the patient and how important it is for them to realize the meaning of this type of information. Our role together is to match that with the clinical information, what we call the phenotype, the expression of a disease. And sometimes it's very well correlated, sometimes it's not that well correlated, and this is work in progress. The knowledge is building up. It has been an amazing journey. I mean, the first locus for a gene disease in the eye was identified in 1984 by Dr. Shomi Bhattacharya in the UK. And at that time, very few people believed that this was useful. Dr. Bhattacharya keeps quoting the fact that when he reported that first at a conference in ophthalmology, one of the absolute top leaders in the field told him, this is useless, doesn't mean anything. And you can be a top leader and you can be wrong. And the truth is that over the past many years, the number of genes that have been identified has been burgeoning, but more importantly, it helps us to understand better the disease. It helps us better to understand how the disease expresses. And now, even better than that, it helps us to provide new potential therapies. You'll hear, maybe we'll discuss that with the new gene therapies that are arriving, but not only gene therapies, many other approaches are happening. But all of this is relying on understanding the language of life, the DNA code, and how it gets into the expression of disease. And this is where the expertise that Hannah and Michelle and the team is deploying is so important to you, the patients, to the families, and to all of us. Because Ken has really pioneered that before I arrived, and we keep working on that together. Maybe before we give these wonderful collaborators the opportunity to describe what they do. Maybe Ken may want to say a few words.
Thank you, Dr. Sahel. You're right. We're very, very lucky to have Hannah, Michelle, and also now Kelly as part of the ocular genetics team. I must say that when I first came and I said that I wanted dedicated ophthalmic genetic counselors, people did raise their eyebrows a little bit at Children's Hospital, but we have shown the value of having a dedicated ocular genetic counseling team. And I must pay an acknowledgement to you, Dr. Sahel, because until you came along, I was a sort of a lone voice at UPMC Eye Department, but with your help and encouragement, we've grown. I think it's really important that we understand that we work as a team. So the genetic counselors are just as important as the physicians, and it's that environment that's allowed the whole thing to grow. So I'm looking forward to hearing what Hannah and Michelle have to say. Thank you.
Thank you.
Great. Well, thank you so much for all those excellent introductions as far as our content today. I have been fortunate to have been involved in ocular genetic counseling here for almost 10 years. And today, in thinking about how it's expanded for our patients and the capabilities that we have in translating that from what people think of as simply a laboratory test to your medical care. I titled this presentation, More Than Meets the Eye, Genetic Counseling and Ophthalmology, because it's not simply a laboratory test that you would get for routine care. This is really part of a process and a patient and family experience to understanding what this means for your eye care and beyond. So we're hoping today to give you an overview of the genetic counseling process, specifically how our team works at UPMC, a little bit of an overview of genetics, the testing options that exist today, and how they may be interpreted and impact your care, and what this may mean as all this information just continues to expand. So essentially, the concept of genetic counseling, this profession has only been around formally since maybe 50 years ago. Programs to train genetic counselors came around in the 60s and 70s. And really the purpose was to take the new knowledge and medical information about genetics and be able to translate that to patients. So our role is really to help people understand and then adapt to how this information is impacting their medical care. And this may come from that true medical perspective of there now is another name or explanation for a diagnosis. It could give a prognosis for somebody's condition or link it to their other known health problems. maybe connect them to more surveillance and care. But also there's the whole psychological dimension of genetic counseling, where what does this mean for you, your family members? How does learning this information change the perception of who you are, how you're related to your family members and their medical care or health, and thinking about those different domains that come in with needing resources and support, things that can really change from that personal and mental aspect to be sure that we're addressing those as part of this process. And lastly, we have those family implications. Certainly, what does that mean for someone's children or future children, their brothers and sisters and parents? And that's why I think of it as a process or an experience for a patient or family, because it is often more than just about the person getting testing. And so our role really does expand to all of this. And there are this excellent website about geneticcounseling.com that can inform you more about how this process works generally outside of just our ophthalmology practice. But we play this myriad of roles in concert with our physicians to be sure that we're continuing to discuss your results and educate patients and families as we learn more, personalizing it to your exact care, providing that support and giving you that power to take this information beyond just our eye clinic, maybe to other providers, to other family members, and making that true connection to what we're all striving for is therapies that are emerging. And really, genetic counselors, beyond the world of ophthalmology, exist in many settings, and you may have interacted with them in different clinics or settings, from a hospital to a telehealth visit. There's laboratory counselors that help support what we do, and of course, the whole realm of research to push this information forward. And it's moved into many spaces and subspecialties. As far as ophthalmology, still a very growing area. To my knowledge, there's only about between 50 and 75 ophthalmic genetic counselors in North America. And we here at UPMC are very fortunate to have a team of 3. And so this here is our primary team and all my co-presenters today, and then Kelly Trippy, our new addition as well. So we have been a growing team. Really, I should show all of the providers at the UPMC Eye Center and children's ophthalmology clinics, because we work in concert with all of our doctors here, but this is our primary team. And when we think about how our care at UPMC has been designed, is we have spanning from newborn all the way through adult care with our UPMC Eye Center here, showing our soon-to-be new vision and rehabilitation tower, and the Children's Hospital. And we really offer an integrated model of care, which again here at UPMC is a very unique perspective that I take a lot of appreciation and value in, because we are in the clinic while your physician appointment is happening in ophthalmology. That way, if something is changing, something new is identified, if we've learned more information, we are there to provide that information at that point and remain within our team approach, where we're not communicating outside of our clinic or our hospital and disjointing care in that way. And this model has really allowed us to make sure that we're staying in touch with not just those medical needs, but for children, when it comes to a school setting, needing to liaise with educators, rehabilitation services. For our adults, thinking about what that means vocationally and with other support systems in our community. We're able to branch all of those aspects and keep it all within our team to make sure that that's a concerted approach. When we think about actually what is genetic counseling, what might someone expect from meeting with an ocular genetic counselor, I like to think of it in 3 different phases. And I often describe it as a journey that we may take together, because this information is certainly not something that we meet once or twice about and that resource is gone. So to know what to expect when you may meet with someone for the first time, we are gathering those medical and family histories, incorporating everything that we've learned from that ophthalmic examination and imaging that was performed. We review genetic concepts, which Michelle will talk on today as a baseline set of knowledge, where we're really trying to get an idea of what do you know, what is your background and information that maybe you've read or heard. How can we marry all of that together to be sure that we can talk about this in a way that is translated directly to your care? And we use this opportunity to explore testing options, because everybody's situation may be different. Someone may be the only person in their family with a condition, or have a very strong family history. Someone may know the genetic disorder in their eyes already in their family. All of this impacts what may be available to you. And this also happens upon our first meeting. And really, it's a chance to inform yourself and your family members about what is available, what could this tell me, and what can this not tell me when I do a genetic test, because not everything is a yes, no answer or very clear. And we'll touch more on how this may impact what happens when results come back. A big phase, at least in the United States, in our insurance atmosphere, is this part of genetic testing where it's not immediately meet us and get access to genetic testing, although we wish it was that easy. There is a lot of work that has to happen with your insurance company. There may be costs to you. We may have to work within their process to make sure this is something patients can access, and we act as advocates on your behalf to make that happen. We also help you with collecting samples, which is now easier than ever. A lot of genetic tests are able to be done with a cheek swab rather than a laboratory visit. And we are that liaison with those laboratories to make sure we're getting your results in a timely manner. So this is another process we help usher you through as people who have maintained those relationships and that expertise to be sure we get to this point smoothly for care. And then the big crux of the genetic counseling when the results come back is to think about what did that test result show in relationship to you yourself as the patient and to your family. Looking at this in-depth data as it expands and knowledge gets greater every day. Were you tested for the right things? Can we revisit this test result? Should we be doing something more for you? And how has knowledge changed about what we found for you and what is new and upcoming? We review all the results and discuss your eye care implications, your future health, how this may relate to other providers, and loop in your primary care teams. And this also allows us to identify potentially more resources and clinical trials, research opportunities with some of this information. And we help coordinate that follow-up process to be sure that this isn't, as I mentioned, we meet for results and that's the end of our journey together. We really continue to make sure that this important information about your genetics becomes an integral part of your care and personalize it to be sure that it is tailored to what you need. And when we think about who in the world of ophthalmology should consider genetic counseling, if you're asking yourself, is this something that could be right for me? While this is not inclusive, these are some characteristics that make us consider eye conditions that we should delve more into. So we have two eyes when conditions are bilateral or in both eyes. If it's typically a more severe condition or a very early onset condition, there are certainly genetic components and family components to many eye diseases, but not all that maybe have a medical genetic test available. When we think about more common eye conditions like glaucoma and cataracts, seeing those with age, we don't have genetic pinpointed reasons, but when we see them in infants or children, we can access some more testing. And I'm sure with time we'll learn what those different family patterns are that make this occur anyway, even in our patients we see in our adult centers. That personal and often combining with that family history or those family stories of similar symptoms in your family can point us there, as well as people who have multiple or lifelong health conditions. If you have, for example, a dual sensory impairment, visually impaired and hearing impaired, if you've needed a kidney transplant, if you have a cardiac condition, these may be related to things happening in your eye. And we're able to use the information and power of eye exams and imaging with our physicians to combine it with genetics. So these are just a few, but some things that make us look more closely for sure. And when we think of different eye conditions that may in fact be genetic, again, it's a very long list. Just to give you some examples, if you have a birth defect in the eye, if you have a corneal dystrophy or a corneal disorder where it's been clouded from birth, or you have a strong family history of that. As I mentioned, glaucoma, increased pressure in the eye in infants and children, or that very strong family pattern where it's coming from grandparents, parents to their children. Thinking the same pattern for those early onset cataracts or unusual patterns in the cataract. Inherited retinal dystrophies, of course. There are many names for this, but retinal dystrophy is certainly our umbrella term. retinitis pigmentosa, rod cone dystrophy, cone rod, choroideremia, achromatopsia, very many terms to describe these. Essentially that dysfunction in the retina with risk for progressive vision loss or sometimes stable. These are families we should be seeing to discuss and explain this sort of condition in the family. And our optic nerve diseases, whether an optic nerve has atrophied or died off over time, or sometimes in your eye exam, it may be described as a pale optic nerve. Again, assessing why this has happened, because there are some risks for other health problems that may occur with this, and prognosis information or therapies that are coming available for this realm as well. And there certainly are many more. So thinking about those characteristics in your own personal health and your family history, and having that conversation with your provider about, is this something that could be appropriate for what you're seeing in my family, is certainly a good conversation point. And if we're seeing you here at the Eye Center, those conversations can certainly be happening within those appointments. So that was my overview as far as what are we doing here, how do we access genetic counseling and testing. So I'm going to actually pass it to Michelle Alabek now, who I am so glad to have recruited onto our team in 2018. She has been an amazing resource for all of our retinal dystrophy patients and expanding our care at the Adult Center in concert with Dr. Sahel and our providers there.
Okay, so I have the pleasure, after Hannah has given you kind of the overview, to give some information about kind of the background of things that are going on in a session when we're meeting with a patient. And this is going to be a very brief overview because, typically a session at that pre-test visit is going to be, anywhere from half hour to an hour potentially. But we wanted to just give you some background on the type of information that we may be going over. And so just to kind of take it back to what I'll call genetics 101, if you think of how we carry our genetic information, it's found in our DNA. And the DNA is in the center of every cell in our body. Hannah, I'm having some issue with the control. If you can stop. Yep. Okay. Is that working now? So Hannah, I don't know if you want to take control back and maybe we can just go next slide. I'm not sure what happened. So can you go back, Hannah? Okay, so we can just, yep, this slide's fine. So we carry our genetic information in the center of all of our cells. It's found in the nucleus, and that's our DNA. And DNA is kind of packaged tightly into these structures that we call chromosomes. Chromosomes are basically just kind of bars of information that have DNA within them. Humans have 23 pairs of chromosomes, and each chromosome can contain hundreds to thousands of genes. A gene is a specific segment of DNA, and that segment of DNA is coding for a specific protein that has some function in the body. So I have on the bottom of this slide, if you can see, an analogy that I like to use where, you can think of DNA or genetic information kind of like an encyclopedia, where your DNA is all of that information that's combined in all of the different books that are in the series. And the chromosome is really just one chapter of that book. And within that chromosome, you can see many, many different genes that kind of live within that given chapter. So if you want to go to the next slide, Hannah. So humans have around 20,000 genes. And as I said, each gene codes for a specific protein that has some function or some job within the body. So this is an example. If you think of a gene kind of like a sentence, if this is what the sentence is supposed to look like, then this is what, it can do its job, it can function in the body. And so the protein's working. If you can click, Hannah. there are a couple examples, maybe the entire gene is missing, or there's a word that's missing from the sentence, or something spelled wrong in the sentence. And if there's a difference in that gene or it's missing, it can't do its job. It's not making the protein that it needs to make. And that ultimately is what can lead to a genetic condition. So you can go next. So when we think about what is genetic testing, kind of in the simplest form, we're trying to find what is the genetic cause for an individual's condition. And you can equate that kind of like looking for a needle in a haystack. So the needle is what is the genetic cause of this patient's condition. And the haystack is kind of all of that genetic information that you have to sift through to try and find it. So if you have too much hay to sift through, you might never find your answer. If you look in the completely wrong haystack, you might not find your answer. And so really, with the amount of genetic tests that are available, it's really critical to make sure that you are picking the correct test that's most likely to give you an answer. To do that, as Hannah had pointed out, there's a lot of information that we take into consideration, things like what's the diagnosis, what's the ocular imaging showing, what are the other systems of the body that the patient may have affected, and also what's the family history look like. So most often we start kind of in this middle category, I would say is the most common type of test that we order, which is called a phenotype driven panel. So this would be an example of, a patient that has an inherited retinal dystrophy, and we're going to target all of the genes that are known to be associated with an inherited retinal dystrophy. Similarly, if a patient has congenital cataracts, you're only going to target on a panel the genes that are known to be associated with cataracts. And you can go up and down this ladder depending on the information that you've gathered from a patient in their history as well as from the family. There might be enough information that we're confident in targeting a single gene or potentially even just a specific change within a single gene. Again, that depends on the information that we've gathered ahead of time and why that pre-test session really is so critical. Alternately, you can kind of go down this pyramid, and there may be more complex cases where a single phenotype panel isn't going to be enough, and you need to order a larger test like a whole exome sequencing, which is looking at all of the coding regions that code for proteins in your DNA. And then even more broadly than that, there's testing available called whole genome sequencing, which has some limited clinical utility at this point, but is analyzing other more unique regions of the DNA that don't specifically code for proteins. So again, I can't stress enough the importance of really that pre-test session and gathering the information, not just of the eye history, but really the rest of the patient's history and family history, because it helps us to decide what is the best test for a patient. So you can go to the next slide. So when we do testing, once we decide what test we're going to order, once we get the result back, you have to interpret that test within the context of the patient themselves and their family. So regardless of what test you might order, it's going to fall somewhere on the spectrum from positive. And in those cases, it means you find an answer. We know that the genetic changes that were found are significant. It fits with the patient's presentation and their family history, and we're confident that this is our answer. On the other end of the spectrum, you can get a negative result. And in this situation, it means that we really didn't find anything. And we can't say that it's not genetic. All that we can say is that the test that we ordered isn't able to find a genetic cause. And this negative result really goes back to making, when you get a negative result, did you pick a test that could find what you were truly looking for? Or is there maybe another test that you should order on top of that at this point? And then you can have results that fall into the middle in this kind of inconclusive, or what you might call a gray zone. Maybe the test found something, but we're not sure if it's a significant change or not. Maybe it found something, but it's not in the right combination to cause a genetic condition, or it's not powerful enough to cause a genetic condition by itself. So, any genetic test, once we get the result back from the laboratory, ultimately as providers, we're trying to kind of categorize it into one of these three categories, because that's how we are going to help to determine what is the benefit of this result to the patient. Most often, a positive result is going to be the most beneficial. And so, Hannah, if you want to go to the next slide. When we get a positive result, it can have a lot of different impacts for a patient. One of them is that it can give us a diagnosis. And for patients where maybe they haven't had an answer to their symptoms before, or they had unexplained symptoms that no one could explain, we can often give a name to a diagnosis or to a symptom that they've never been given before, and it gives them something to kind of a solid foundation to kind of hold on to and relate to. A positive test result can also give us information about prognosis. It's definitely not a crystal ball to get a positive test result back, but it can provide us with kind of a roadmap. It can give us the ability to give the patient guidance, set some expectations about what the path may look like for their future. What are some of the obstacles or barriers that we think they may encounter along the way, and really kind of help them anticipate what their future could look like. Another outcome of a positive test result is really treatment options. And I think this is a really important one. The benefit of identifying an underlying genetic cause and knowing why something is happening in a patient is really so that you can personalize their treatment. What is the best option for this patient given what is causing their condition? And this may include things like therapy. There's a lot of talk about things like gene therapy once we identify a genetic cause. There are other medications for things like optic neuropathy that can be taken once you know that you have a specific cause for that condition. There can also be surgical implications, that you might choose a certain procedure or a certain type of surgery, or choose when to do that procedure or surgery based on what the patient's underlying diagnosis and genetic cause may be. Another outcome is personalized management. And this is for the eye, meaning, once we know the cause, we can also know maybe how often should we be following up with you? Should it be every 6 months? Should it be every year? Should it be every 2 years? Based on what we're expecting with this condition, what is an appropriate follow-up plan? And also, what types of tests should we be doing to monitor your ocular health now that we know the underlying cause? It also can give us information from an extraocular, outside of the eye, features. So there are some genetic conditions that affect the eye that also may impact other parts of the body, like the hearing or the kidney. And if we are aware of a genetic diagnosis that sheds some light into risks of other parts of the body as well, we can really help patients to kind of proactively establish care with other specialties to make sure that they're getting the right screening and management as early as possible. The last real benefit to a positive test result is giving specific information to risks for relatives. And I think, once we identify a genetic cause for a patient, obviously, the patient in front of us is the primary point of contact, but we share genetic information with our relatives. Different genes are passed through families in different ways. And if we know what the cause is in a given individual, we can really spend some time talking with them about what this means for other family members, which relatives may be at risk and may benefit from additional evaluation. And if those relatives are interested, helping to connect them with the right providers, either locally or finding them someone near where they live. So there's a lot that a positive genetic test can do. But there are limitations to genetic testing as well. And it's not perfect. I think everybody wants an answer, especially if they've lived with a condition for a while or unexplained symptoms. But genetic testing is not perfect. It's not always kind of a golden ticket that you get an answer right away. Sometimes it can become quite a bit of what we call a diagnostic odyssey. It's a long, choppy journey. There's multiple stops along the way, some that you're not expecting, some that you might be expecting, really on this journey, as Hannah described at the beginning, to try and help patients find a diagnosis. Another limitation really is just knowledge. Our ability as genetic counselors and working with ophthalmologists, our ability to apply genetic information to clinical care is limited by what we know. And the field is growing, dramatically, but we're learning more. And as we learn more, we'll be able to hopefully apply it to even more cases. Currently we can't find genetic causes for every condition, even if we assume that the patient has a genetic diagnosis. The last one that I put on here, it's really not a limitation of testing necessarily, but I think just an important point to bring up. In my experience working with patients, a common motivation for them to have genetic testing or to pursue testing is because they want to become eligible for a gene therapy or a gene specific treatment or potentially a cure. And I think it's important to recognize that there certainly are some genes that have that available currently, but it is not something that every genetic positive result is going to have a treatment to offer. And so that's something that, as Hannah mentioned, when we're talking to patients in the pre-test session, it's not just what can this test result do for you, but also, making sure that you have realistic expectations of what it can and can't do. Also, just because you don't have a genetic answer found for a condition, it doesn't mean that there's not a therapy or a treatment that's available. So I think there's a lot of hope that patients put on finding what their underlying genetic cause is. And I guess the point of including it on this slide is just that that's not the end all be all of determining if someone's eligible for a treatment or not. Next slide. So, if you think about everything that Hannah's talked about, how we apply this at UPMC and some of the different benefits and limitations of testing, I just wanted to kind of outline what's coming next for genetics in the ophthalmology realm. Development of new therapies is really one of the things that I think everyone is most excited about. There are dozens of therapies that are in clinical trials specific to genetic eye diseases, and it's really, expanding rapidly as we move forward. Some of those therapies require a specific genetic cause to be known, and others don't. And so again, we just have to wait for this field to evolve. And we're lucky at UPMC that we're kind of in the thick of it as these new therapies are being developed, and that we're able to not only have researchers working on developing these therapies here, but that we're also able to offer some of these clinical trials to our patients. Another future direction, I think we're only going to gain more information about new genes and how they relate to our eye health. We're only going to get better at how advanced our genetic testing technology is. And these two things together are really going to increase the number of patients that have a genetic disease that we can find their answer for them. Another point I think moving forward is really how do patients in ophthalmology have access to genetic counseling and to genetic testing. And I think there are a lot of ways that this is advancing and will only continue to advance as well. So, with telemedicine and virtual consults becoming available, this is something that we're able to begin offering to our patients to connect, outside of a physical clinic visit, to make it more accessible for patients, especially those who may have low vision and have difficulty with transportation. Another way that the field of ocular genetics is really helping to expand genetic counseling and testing to patients is a lot of organizations and pharmaceutical companies and laboratories are partnering together to offer free genetic testing for certain subsets of patients. And the point of that is really to get these technologies available routinely to any patient who may benefit from them. And the last point here, and it's last, but I think probably I could argue the most important, we really need to be continuing to assess how the patient is experiencing the field of ocular genetics, especially as these new therapies are developing. We're here to help meet the needs of the patient along this journey. And so we really need to be exploring what the patient experience is and how we can help to continue to support that moving forward as the field continues to expand. So Hannah kind of mentioned at the beginning who generally may benefit from genetic counseling. What are some of the features you might consider? So I just wanted to kind of wrap up with this slide. You might be sitting there thinking, well, would I benefit from genetic counseling? So a couple suggestions or things that might help you decide. Talk to your doctor about it. See what your doctor says about your diagnosis. If it's known to be one that can be associated with a genetic cause. Another thing you can do is just have a good summary of your own health history, not just your eye history, and how that has progressed or when it was diagnosed, but other parts of the body as well, different diagnoses you may have been given. Because as we said, sometimes things may seem unrelated, but if we know that a patient has multiple things, we can sometimes find a genetic diagnosis that can explain different things. Another thing that is good for anyone to do is to talk to your family about what their medical health history is. There's actually an initiative on Thanksgiving Day. It's called Family Health History Day, because you're sitting around the table, engaging with family members, and it may be a topic that's not very comfortable for some, and certainly your family best, but the more that we're sharing and discussing our family history with our relatives, the more that genetic counselors and providers can use that information to really help personalize care and management. And lastly, I just included on here, certainly if you're a patient at the UPMC Eye Center, if you live in the area, we're happy to be a resource for you and to help provide our services. If you live not around here or have a non-ocular related reason that you feel you might benefit from genetic counseling, here's a link here that is through the National Society of Genetic Counselors. You can type in, the area where you live and what type of genetic counseling you might be looking for. They can help you identify a genetic counselor specifically, or a genetics clinic that might be a good resource for you. So that's all the prepared presentation that we have. I just want to open it up for questions. I think Lonnie is going to help to manage this part of it, but thank you.
Yeah. Well, thank you both, Michelle, Hannah, and so welcome again to all of our panelists to this session with the questions and answers. So for our audience, please use the bubble below to type in your questions. We have a few already, which I'll get to. And there's got to be more questions, because it's really a new and fascinating topic that we're at a point where we can actually, with our patients, start off with a genetic counselor to understand their condition better, so then you can look at their treatment options. And again, this is something that was talked about and maybe in sort of a wishful thinking mode not too long ago. So the fact that we're doing that and doing that so strongly, it's really a credit to the work that we're all trying to accomplish. So congratulations, it's exciting to see this. So, well, first question is just this: how or why does a patient get referred for ophthalmology genetic counseling?
So I think I can start with answering that. Hannah, obviously feel free to chime in, but within our department, any physician who sees a patient that they feel may have some underlying genetic cause, or that they want to further evaluate the possibility of a genetic cause, just refers the patient to our team. So we have it set up, through our electronic medical records. They can send a referral. Oftentimes we're seeing them in clinic. We're right down the hall, whether it be at Children's or here in the Oakland facility, that they just, pop in our office and say, hey, I have a patient that I'd like to get more information. Can you document their family history? Can you help me decide if a genetic test would be right for them? And if so, which one? So it really is just dialogue between our physicians and our team of genetic counselors here as well. We do sometimes get referrals from outside. So if if it's not a patient that's seen by one of our UPMC providers in our eye department, we have to, because as we explained in the session, the phenotype, that clinical data, what does the eye look like? What are the features that we're seeing on the testing is so critical for us as genetic counselors to be able to pick the right test, that in order for our team of genetic counselors to provide genetic testing and that service, we have to have that come through one of our physicians so that we can really partner with them and help to make a decision about what's the best test for them.
Well, so what are some examples of medical issues that would trigger a broad genome testing versus extremely targeted?
Sure, I can take that one. So when it comes to the extremely targeted tests, as Michelle had laid out, that needle in the haystack would be, you already know, you maybe have a relative in your family who previously went through a process of genetic testing, and they themselves have a report that has exactly the condition and the mutation or genetic variant in your family on paper. If your condition matches up with what we expect to see with that, then that would be the approach where we say this is the most targeted, the most diagnostic, and can assess your risk accurately in thinking about you and your family. Then it becomes more broad. When we think about broad genome testing, as was mentioned in the attendees question, it really comes down to curating your panel. So we have a lot of success here as far as knowing what the condition is, seeing that deep phenotype, and making sure that we're assessing all known genes. And we start to pull in broader testing in patients who have something that may be ocular, plus another condition, maybe like hearing loss, cardiomyopathy, a nerve disorder, something where we can't easily put those two conditions together, but think that they may be related, there are conditions out there that relate these two. I think of it, needle in a haystack is good, as well as casting that wide net. The wider we can cast it, the more we can try to be inclusive of your health and your family's health. But with that, we have to balance the risk of information that we may not be able to interpret. So they balance out, and as part of that discussion, always something we want to address, because more information can be helpful for some and actually really muddy the waters for others.
Oh, that is, I imagine that makes it complicated for you. And so is the gene database stored at UPMC, or is the swab compared to a scientific national database?
You want me to take that one, Hannah? We could just kind of go forth. So the majority of the testing that we're doing here at UPMC in the department, and certainly not all of it, but the majority of it is clinical testing, where it's done at an outside laboratory, that has their own internal data, where they're, comparing what have they seen before in their lab to what they're finding on the patient sample that we've sent for testing. The laboratories themselves all follow and have specific guidelines of what types of variants or mutations they should report. They compare those to national databases, other genetics community type databases, where different laboratories can see what other laboratories have reported in their own institution. Because really, when it comes to genetics, the more data that you have, the more useful you can make that data for the individual patient that's sitting in front of you. So, when we order a clinical test, it gets sent out to an outside laboratory. That laboratory is reporting the result back to us, and it becomes a part of the patient's clinical chart. We, within our department, keep a separate database of patients that have certain genetic conditions, which is actually how we'll help to identify patients that might be eligible for trials, et cetera, based on their genetic results.
So you're not looking up the data on 23andMe or anything like that.
No.
So,
But
okay.
just to be very clear also on that, the confidentiality is total. I mean, there is no communication of any information except to the patient himself or herself. Absolute confidentiality of the data, and it's very, very, very protected. Maybe just to make sure that I mentioned that, we benefit a lot from the support of Foundation Fighting Blindness. They put together My Retina Tracker, which is a voluntary registry where patients can contribute, and again, this is protecting their data, and it's providing to us and to many physicians free genetic testing for retinal dystrophies. And I think it was mentioned by Michelle already, but this is something that has made a big difference in terms of coverage, because before that, it was very difficult for people to get covered for that. And they also provide, but we don't need that in our department, some genetic counseling, but in our department, we have the experts on site, which is even better. So this is a major program that is growing, and actually is going to lead to many more opportunities for patients.
Fantastic. In your experience, how often do the results come back positive, inconclusive, and negative? I guess 100% of all three of those, but maybe how often positive?
Right. And, for this question, it really depends on the reason the person got tested, because for individual conditions of the eye, what we know genetically that causes them can vary. So when I think about our patients who have optic atrophy or had congenital glaucoma come on before the age of 3, we're having a detection rate, I'd say 80 to 90% of a positive test result. I can think of few families that were inconclusive or negative, and that's because the realm of what we know that causes this condition is more well known. When it comes to our inherited retinal dystrophy population, Michelle and I have done an audit to show exactly this question, and we're finding that about 60% of our patients are receiving a conclusive or positive answer, and that's in accordance with what other centers and is what's being reported in scientific journals. This number will, of course, increase as more is known and we're revisiting testing and knowledge is expanding. And these are percentages that, if we know them, we do share with you as part of a genetic counseling session when it comes to your exact situation, whether your personal or your family health.
So this is for Michelle and Hannah. What made you choose the field of genetic counseling? Actually, that is a good question because it is very specific, and it's also, you're very specific to ophthalmology. So what made you choose to get into this?
Yeah, I think, I mean, my path was more just, I found out about this profession when I was in my senior year of college, and I thought I might go to med school and I thought I might be a teacher. And then I learned about genetic counseling, and it kind of meshes that kind of medical side of things as well as the direct patient interaction, some probabilities and statistics, but really feeling like you're having that one-on-one connection with patients and helping them was something that was appealing. The ophthalmology specific piece of it, I think, we've touched on some general genetic information, but also some that's specific to the eye. You can imagine, I mean, the amount of knowledge that we have just about ocular genetics is growing exponentially all the time. Carry that over to every other system of the body, and it's really hard to keep up to date with everything. Mm-hmm. Personally, and I don't know if Hannah wants to chime in, but I tend to gravitate towards specialty genetic counseling. Some genetic counselors, as she mentioned early on, will practice in a more generic setting. And we need genetic counselors to do that as well. But I really find a lot of fulfillment and enjoyment in feeling like I'm becoming an expert in a specific area because I can know that material that much more in detail.
Great.
Sure. And, my pathway in thinking about how I got here was I was always interested in genetics. When I was in high school and started looking into what majors I wanted in college. And so I had majored in molecular biology and had internships in, doing bench science and thinking about what I want to take this clinical. I did like a translational research internship, and none of them gave me all the aspects I was looking for. And when I was actually doing an internship at McGee Women's Hospital here, I had met some genetic counselors who work in that setting, and it expanded my interest. So it was through kind of trying a couple different medical specialties, all that, put genetics into now what we can deliver to a patient setting, that really kept my interest there. And, same as Michelle, I've always been a specialty genetic counselor. And when Dr. Nischal had come to UPMC, he was, as you mentioned, searching for an ocular genetic counselor, and we actually worked down the hall from each other and didn't know each other. And I just, really thought this was interesting. We don't really get taught ocular genetics in our professional program. And so it was a definite learning experience for me, and I can credit him for a lot of my ocular knowledge, and we've really worked together and with all of our providers. I landed in it, and now I wouldn't change it for anything.
And now you need to start writing the book on it, is what it sounds like. So,
with all the co-authors here.
Do you consult with other specialties in genetic counseling? So, such as when relationships like dry eye can cause, from rheumatology, can cause Sjogren's or other things like that. Do you consult with those other specialists?
Yeah, so I think, you have to approach it, and this is where really partnering with the ophthalmologist as the physician who's caring for this patient and thinking of the patient as a whole. We want to find a genetic answer if we can for patients, but sometimes it's not a genetic answer, or it might be stemming from some other systemic involvement. And so certainly you have to kind of think of the patient as a whole, and working with other specialties to try and tease out, what is relevant and what may not be relevant. But certainly we coordinate with other specialties very, very frequently.
So this next question, actually, we did a whole program on myopia, but is there a solid genetic basis for why myopia, one of the most common visual problems worldwide, develops, or is it still largely a multi-gene issue and hard to assess?
Maybe Ken. Yeah.
I might take that one. I think this is a very important question. So genome-wide association studies have shown that there are certain loci or loci, depending on how you want to say it, that are associated with a higher incidence of myopia. In Singapore and in Taiwan, they have done some work where they've looked at how some children with myopia don't respond to some of the treatments that we have. And I think what will happen is we will get to the stage in the next 5 to 10 years where we will be able to do some genetic testing prior to trying to use myopia arresting therapies to see if those therapies are going to work in those patients or not. But I don't think we're at the stage where we can say, well, you've got this gene, this is the amount of myopia you're going to get, because we know that the environmental influence on myopia development is strong, unless you have a connective tissue disorder, in which case it's a completely different type of condition which you can't sort of control. So the answer is we are getting there, but we're not there yet.
It is a great question. I definitely reference you back to the myopia webinar that we did maybe a few months ago, which is on our website for the Eye and Ear Foundation. So you mentioned that pharma companies are interested in genetic counseling. Is UPMC working with pharma companies on targeted treatments for genetic disorders?
Maybe I can take that one. Well, we are in the sense that sometimes we develop ourselves some of these therapies, and we have to find the industrial partner to bring a great scientific achievement into a product that could be tested and brought to patients. And this is something I've done for many years and others are doing, and this is happening. On the other side, we want to be able to offer to our patients the best opportunities. So everything we do is really driven by the idea that is this trial, is this new product potentially useful for the patient, or are we still unsure about the benefits? So this is where we are driven not to work with pharma because we want to work with pharma, but this is because they are providing opportunities that can be useful to our patients. And currently this is happening in many fields. It's happening in gene therapy. Currently in gene therapy, there are more than 20, probably 30 trials that are ongoing, and we are involved in many of these. Drug therapies, we are currently working on a very innovative treatment for Stargardt disease, for example, and also working on the potentially stem cell therapy, although we are very cautious about that. And there are many other approaches like artificial retina and others. So we have to work with industry because this is the only way where innovation is going to reach the patients. But we are doing that from the angle of the patient always. And this is based on the genetic testing. Currently, you cannot, for genetic diseases, even in the future for age-related macular degeneration, it's very likely that the therapy will be totally personalized based on what we call the phenotypic expression of the disease, how the disease is evolving, the stage of the disease, but also the genetic background and a lot of information. So it's a very personalized approach that is building up with new technologies, which is good news actually. And the industry is bringing us to us opportunities, and the partnership is how does it fit with the priorities we have for our own patients.
One last question. I think this we can answer, even though it's a little bit personal, but are retinal tears genetic? Things like retinal tears, and can it be genetic to the point that children should be tested if you've had retinal tears?
So, I mean, I think any of us could answer that. And it depends on several things. But if there are certain features about a retinal tear, and Dr. Sahel will know this better than I would, but that you see and you and about the eye that make you think that there could be an underlying genetic predisposition. Without going into exact details, there are many children that we have at CHP whose parents had retinal detachments, and the children are then screened, and some of them do have them and some of them don't. But there are some specific ocular signs for very specific conditions. So the answer is yes, but you want to be guided by, in this particular case, by the eye health carer that's looking after the adult to decide whether there are these specific signs before you would start to examine the family.
Okay. Well, and I imagine that there are probably a lot of things we don't know yet that are genetically predisposed, and I guess it's one of the things we're learning here as we go. Fantastic presentation, everybody. Thank you so very much. And we are right at the hour, so also congratulations on being perfectly on time. Thank you for doing this for us. Thank you for our audience that attended today. As I said, we will be sending out surveys tomorrow. Please help us with those. And this will be recorded on and saved at the Eye and Ear Foundation website for future viewing for you and anybody else who missed it today. Thank you. You have a wonderful day and enjoy the beautiful sunshine we have here in Pittsburgh. All right. Have a great